And welcome to the Research Works podcast, brought to you in association with Curtin University and the Healthy Strides Foundation. Your hosts are Dr. Dana Poole and Dr. Ashley Thornton, and together we will interview world-leading researchers in the area of child health to support your practice in being more evidence-based.
Welcome back to the Research Works podcast. Today we are both super excited because we have an amazing opportunity ahead of us to speak with Dr. Michelle Jackman. Michelle is the lead author of the recently published International Clinical Practice Guideline for Children and Young People with Cerebral Palsy. Hi, Michelle.
Hi guys, thanks so much for having me.
Oh, thanks so much for being on the show. I was actually so excited to see this published. I've known it's been in the works for a little bit of time now and talking to some other colleagues and it's for me it was like waiting for that next season of your favourite show to drop where you know it's coming but you don't quite know when, and then you hear it has and there you are downloading it going, this is what I've been waiting for.
Refresh.
So lots of excitement on our end here, Michelle.
Yeah.
That's so awesome to hear.
And I think it's amazing that research, in this field is now at the point where we're actually developing these clinical guidelines based on the latest evidence. And I think it really reflects the joint efforts of researchers, clinicians, funders, obviously children and young people and their families that has enabled the evidence to be compiled in this way. So thank you so much, Michelle, for firstly, leading it and also taking the time to speak with us today about it.
No, it's awesome. It's great to have an opportunity to talk about it and finally get these recommendations and this guideline out into the public space.
Yeah, absolutely. I'm sure it was a real labour of love.
Absolutely. In the end, it was.
Yeah. So for our listeners, the article that we're actually talking about today is titled Interventions to Improve Physical Function for Children and Young People with Cerebral Palsy, International Clinical Practice Guideline. This was published in September 2021 in Developmental Medicine and Child Neurology. And to give our listeners a bit more background about Michelle, Dr. Michelle Jackman is a research paediatric occupational therapist currently based at the John Hunter Children's Hospital in Newcastle, New South Wales, and the University of Queensland in Brisbane, Queensland. Having received her PhD in 2018, Michelle's publications reflect broad collaborations with world leaders in cerebral palsy research. Her work in the area of occupational therapy has provided some really important steps forward in understanding threshold dosages for upper limb training and the co-op approach or cognitive orientation to daily occupational performance. And the clinical implications of this area we think are just, really vital for providing guidance to clinical decision-making and planning. This recent publication is another vital step forward with an authorship group that includes Leanne Saczewski, Catherine Morgan, Rosalind Boyd, Sue Brennan, Catherine Langdon, Rachel Tuvey, Susan Greaves, Megan Thorley and Iona Novak.
That's very impressive, actually, Michelle, isn't it? When you go through what has been achieved there and the team that represents.
So, Michelle, we like to start our episodes with a little icebreaker question so that we can all get to know each other a bit better. And the question I thought we would ask today is, who is the most famous person you've ever met?
Yeah, I need to think about this because I reckon I've never really met anyone that famous or that is that significant. But I feel like because my surname's Jackman, everybody always assumes that I'm related to Hugh Jackman. So I actually feel like I know him quite well.
Yeah,
he's like
close
Hugh,
personal
even
friend.
Though I've never met him. But I think I had one of those famous moments during this guideline process when it was during lockdown last year, and we organised this big international panel meeting with these amazing physicians and OTs and physios from across the world. And, when you read research papers a lot and you've seen these names so many times and you really, they're such amazing people that have made such contribution to research in the area of CP or paediatrics in general.
Yeah.
So it was actually phenomenal during that meeting. I think I had this real oh my God, I can't believe, I'm on a Zoom meeting with all of these phenomenal people whose name I have seen. So Marina de Brito Brandeo from Brazil and Andy Gordon from the US and so many amazing researchers from around the world. And I'm so lucky to work directly with Iona Novak, who's a bit famous in our field.
Oh,
but,
she's
amazing. So absolutely. So I feel like it was a real like, oh my God moment in that Zoom meeting in lockdown last year, being able to discuss these guidelines with all those phenomenal people. And really, it was so amazing to hear how excited that they all were about these guidelines coming out as well, and to hear that they're so relevant to, really up-to-date research in all areas of the world.
Yeah, I guess that just shows that someone who's famous isn't just fame for fame's sake, but it's like impact. And, you see these names because of the impact it makes on you and your practice. And I think that's really cool.
Yeah.
That's
absolutely.
a really good one.
Yeah.
I don't think I've met anyone, I don't think I've met and had a proper conversation with too many famous people. There was one like really close encounter of Yao Ming. So I saw him.
Super famous.
Yeah, really, really famous. He was here in Perth and he was at Crown checking out this like really impressive Ferrari display or something. And he stood out because obviously we all know he's this, amazing basketballer, and he just stood there in the middle, and I was like, man, that is a really tall person. So I just walked up closely, and I was just around the area, so I didn't actually properly meet him. Recently I met Adam Gilchrist, and he's a very famous cricketer. I did have a bit of a conversation with him, and I kept it cool because I don't know too much about cricket, so I just had to not go there in case I said something really stupid.
Love it.
And then once I met Diane Damiano, I did the same thing at an American Academy conference, and I just walked up to her to ask her a question, and I was like short of breath. I was like heart palpitations as I was about to talk with her, because Diane Damiano has been really influential in my work as a physio.
Absolutely.
What about you?
Well, just before I go on to mine, I just want to say that I'm really sad that there's not photographic evidence of Dana and Yao Min in the same room, because you obviously can't see on the podcast, but Dana, I hope she doesn't mind me saying this, would be considered vertically challenged.
That would be correct. Unfortunately.
So it would be a really wide lens that would that you'd need to capture that. So my most famous person / people is very niche. And you would have to be a big fan of tennis in the 90s to probably appreciate this. But I used to play tennis quite a lot, and I was invited to a clinic at the Hopman Cup, which used to be held in Perth here. And the South African team were running the clinic. So I got to meet Amanda Kurtzer and Wayne Ferreira, who were very good tennis players back in the 90s and early 2000s.
Even I know who they are. That's really cool.
Oh, great.
That is very, very cool.
Me too. And you didn't just meet them, you did like a tennis clinic.
Yeah.
So it's quite impressive.
I hit a lot of balls into the net in front of them. Yeah.
Don't we just love those moments?
Yeah. So Dana, why don't you tell us a little bit about the paper that we're going to discuss today?
Absolutely. Okay, so this is an international clinical practice guideline that aims to provide recommendations for interventions to improve physical function for children and young people with cerebral palsy. With an expert panel to prioritise questions and patient-important outcomes, the grading of recommendations assessment, development and evaluation, or the GRADE method, was used to assess the certainty of evidence to in turn make recommendations with an international expert and consumer consultation. The systematic reviews and the randomized trials that were included in this guideline development needed to have at least 80% of participants with a diagnosis of cerebral palsy, where at least 80% were aged between 2 and 18 years, that were evaluated for interventions that aim to improve physical function using valid, reliable and responsive measures at the activities and participation domains of the ICF. Having been informed by 3 systematic reviews, 30 randomised trials and 5 before and after studies, this guideline provides 13 recommendations for interventions to improve function for children and young people with cerebral palsy. This includes the importance of client-chosen goals and whole task practice of goals, and the need for clinicians to consider child and family preferences, age and ability when selecting specific interventions.
Thank you so much, Dana. Now, Michelle, I obviously have loads of questions for you, and we have lots to cover in this episode today. But I thought we would start right back at the very beginning, and perhaps you could explain to our listeners what an international clinical practice guideline is and why it's important.
Yeah. So I suppose guidelines are a bit different to other publications that we might read, like systematic reviews that are really just looking at the evidence and really just representing what the evidence tells us within a research context.
Yeah.
So really the purpose of a guideline is to put that research into real life context, to be able to make recommendations that are based on evidence but are also realistic and feasible and acceptable. So I think guidelines are a really phenomenal thing, particularly for clinicians, because really it is putting all the existing evidence within a recommendations framework and then really putting it within what is realistic within real life. So the recommendations, I think sometimes as a clinician it's quite frustrating reading research that you think, I just can't apply this in practice, or, you know, who could we apply this to? This is such, you know, a small percentage of the population that I see, or, you know, there's no way I could ever get this much this high enough dose of practice in. So guidelines are really about trying to come up with recommendations that are realistic, that as clinicians we can actually implement in practice. So I think that that's really exciting, and they take into consideration not just that evidence but also what families want, what their values are, and they weigh up benefits and harms and really look at cost effectiveness and accessibility of interventions.
Yeah, I love that. And I love, you know, that you've touched on the really crucial part there, that it being feasible for clinicians to take, you know, these guidelines and implement them into their practice. And so they're all designed about making it, you know, as easy as possible for them to do that, which is fantastic. Could you talk us a little bit through the process of developing the guidelines? So, you know, how did you go about doing that?
Yeah, so I suppose it started probably around 2014, 2015. There was some big summits around the world in which basically consumers and clinicians were asked what they felt were the biggest priority areas for guidelines, where they felt that evidence maybe had changed, or where they felt like there wasn't enough guidance around what they could do or how they could help people. So there was 3 areas that were identified. One, so this is specifically in regards to cerebral palsy. So one was around the early diagnosis, the other was around early intervention, and then the final one was around how we can improve function for children and young people with CP. So that's really where this guideline started, was that the issue was identified by consumers, so children and young people with CP and their families, and clinicians agreed that it was something that was really important. So probably we really got into the nitty-gritty of things about 3 years ago, so it's been a pretty long process, and really it started with looking at what the priority areas were, and then you go through a process of, I suppose, doing multiple systematic reviews, how we normally would, but that's really just one step. And then with that systematic review evidence in mind, you then take that out to clinicians and consumers to discuss whether A, they agree with the recommendations, think they're feasible, and take that to consumers as well and talk about whether those recommendations align with their values, and then look at cost effectiveness and accessibility, not only within context like Australia, but also in low and middle income context. So it's quite a process to go through, and it really, you know, this grade process, people have probably heard of the Cochrane collaboration, and they are, you know, so well known and recognised for how thorough they are with systematic reviews. And so grade is aligned with the Cochrane collaboration. So I would really think of grade as a Cochrane style standard of guidelines around the world.
Wow. I mean, it does reflect a huge body of work, but what that does also say is that it is so reflective of the current state of the evidence because of the breadth that you sort of cast the net, I suppose, and the number of people that were involved in the consultation. So it's not the perspective of one person here. There is, this is a team of researchers from around the world.
Yeah. So
and I think that that's something that's really important to highlight too. That, it really, like, this is a really reliable process that we've gone through. So it's not opinion. It's this, you know, really thorough process that is based on evidence, but also based on a really broad number of experts and consumers from across the globe that have agreed that these recommendations are appropriate and acceptable.
Yeah. So, Michelle, just to kind of give us an idea of the scale that we're talking about here, could you explain to our listeners exactly how many people were involved in the consultation for these guidelines?
Yeah, so over the course, and the way we went about it to capture big numbers of people is we ran workshops within international CP conferences. So there was over 600 people all up amongst those numerous workshops. That helped us go through that evidence and I suppose come up with these recommendations, particularly those evidence-based recommendations that are really specific to interventions. And then so we had our authorship group, which you mentioned earlier, which are an amazing group of Australians. And then we had this broader expert panel, we called them, and that was a group of 17 clinicians from across the globe. We tried to represent as many continents as we could. And we also had 2 expert consumers, I suppose, that really thoroughly went through all the information and who we had quite a few Zooms with to clarify whether things were appropriate from their perspective. So it really was, there was hundreds of people involved in this process.
Yeah. Wow. And again, that sort of reflects the definition of evidence-based practice. You're thinking about the empirical evidence, the clinical expertise, and what, the values of patients and the consumers. So that's a beautiful reflection of that. And it's just great to highlight that that's the process that it had to go through.
Yeah. And no wonder it took, the 3 years plus a little bit more as as you said.
Now, Michelle, this guideline really does cover physical functioning aspect of cerebral palsy. And so why was this the particular focus? We know, today happens to be World Cerebral Palsy Day, and we talk about the impact cerebral palsy and, just raising awareness. We know it affects many facets of life, but it's just important just to know that we are talking about physical functioning in this particular guideline.
Yeah, I think that's really important to highlight. And I think ideally, the guideline would have covered all areas of a person's life because we know we don't want to separate out these areas and, we'd never separate these aspects. And it would be amazing to be able to have a guideline to tell us what is best practice around facilitating social skills and cognition and learning and behaviour and all of those other aspects. But I suppose really we know that over the last 20 years, the evidence has changed quite a bit in terms of physical functioning. And in regards to CP, there's actually quite a big body of evidence around this now. So that was really the reasoning. It also, when you write a guideline, part of it is trying to be really, really specific about what the guideline is about. So when you go through the grade process, they highlight it's really important that you don't try and cover everything, that you try to be quite specific with the recommendations and guidelines that you're trying to come up with. So it would be ideal to have guidelines on all of those things, and we would love to see that happen.
Of course.
But this guideline is really, I suppose, about physical functioning because that was what the target was. And that was what that consumer group identified those many years ago that was needed.
Yeah. I think that's really important just to make sure we are aware that that's what this is all about. And it's a great place to start. So the outcome of all this work was the generation of recommendations, essentially. So in this guideline, you have both the evidence-based recommendations and good practice recommendations. So combined, they produce the 13 recommendations that we've been talking about, which we'll go through very soon. But before we do, can you just talk us through what is an evidence-based recommendation? So, you've got your strong and you've got your conditional. Can you just talk us through that first?
Yeah, so the evidence-based recommendations, and I assume we'll go through those best practice principles separately. So the evidence-based recommendations are really the ones that we have done systematic reviews and found higher-level evidence to support the recommendations within. The good practice recommendations, which we'll talk about probably in a sec, are really more about general standards and expectations. So within the grade format, they have very specific wording around whether you would call a recommendation strong or conditional. And this is probably something that a lot of people are not aware of. And this was something that our group probably grappled with a little bit because it's not language that we would use. And we think that the language around conditional can be a little bit confusing for consumers. I think often if we read something conditional, we would read it as we're not sure whether we should do that. But that's actually not the case in grade. So a strong recommendation would be made when there is very clear evidence and there really is no other option. So when we would do that recommendation for every person with that health condition, whereas a conditional recommendation for would be made when there is not huge bodies of evidence. And when we're thinking of that grade process, you need to keep in mind that it was probably developed for medical conditions in which there is a much greater population. So it's possible to do really large-scale randomized control trials, and also in conditions that are not as heterogeneous as cerebral palsy. So it is actually really hard in the cerebral palsy population, and I think that this is a discussion that will be had in this field around whether the wording of grade is appropriate in CP, because it's actually really hard to do research on the scale that there would be that is needed to make really strong recommendations all the time. But when we make a conditional recommendation for something, it is also acknowledging that there might be multiple intervention options, and that consumers may have options and they may choose from one intervention or another. So it doesn't mean the intervention is not effective or we're not sure whether it works. Actually, if we make a conditional recommendation for something, which is all the recommendations within this guideline, then we're saying it definitely works, but there's options around who we would use it with.
Right. Yep. That's great to clarify.
And then following on from that, Michelle, you've got which you've already touched on briefly, the good practice recommendations. Could you explain to us what good practice recommendations are and how they differ from those evidence-based ones? Yeah,
so good practice recommendations are really those healthcare standards and expectations that have not necessarily been researched, but we would hope clinicians would be using. So they're really based on things like the World Health Organization and the International Classification of Disability Functioning and Health, or the ICF. And I think those were really critical to include within this guideline, because there has been a big shift in healthcare in the last 20 years, particularly around this idea of the clients having much more control over any interventions. And I suppose as clinicians, us being the provider of information and encouraging consumers to make their own decisions based on what works for them, as opposed to as the expert making recommendations without the consumer being involved in that decision-making process.
Yes.
Yeah. And I guess that's a really nice way to start talking about the recommendations now. And your first one was a good practice recommendation, which is client-chosen goals should be set. I know you sort of talked about there a little bit as well, but let's just explore that just a little bit more in terms of why this is important and what should clinicians be doing to ensure that we do this.
Yeah, and I think that, we bandy this idea of goals around quite a bit, but I still think it's something that we could do phenomenally better than we already do. So really we know that best practice standards now are around when we see someone, asking them what's important to them at that point in time and really facilitating or helping them from our perspective with that. And sometimes that will mean that as a physio or an OT or a speechy, that their priorities are not necessarily relevant to us, and that is okay. So I suppose, that first recommendation about asking the child and the family what's important and allowing them to have control over the goals is really speaking to the importance of the client being able to state what their priorities are, and then the goals of therapy, so the thing we're actually working on in therapy, representing those goals.
Yeah. And, I think, again, that highlights the importance of being able to measure how we achieve those goals as well, doesn't it?
Yeah, so it's really, really important to state the goals or have them written down in a really specific and measurable way. And we know that that's actually can really improve things from a clinical perspective. It's important for clinicians to be clear about what we're trying to achieve. If we don't know what we're aiming for, how do we possibly get there? But it's really important for consumers as well. And I think, we probably don't value enough the importance of just writing the goal down so someone can take it home and put it on their fridge. And I think families time and time again feedback that it's so great to have that because they know exactly what they're working towards, and then they know when they've done it. And there really is a lot to be said for the satisfaction that children and families get when they can come back and say, I've done that, we've ticked that box. You know, all this hard work is totally worth it.
Yeah, and it's such a nice way. The process of actually setting the goals is such a nice way of getting everyone on the same page and, you know, aligning everyone's, you know, points of view on paper that, you know, this is what we're working towards. You know, this is, you know, it's going to be a team job now to get this done. Yeah,
I love that.
Yeah, I think that's such a beautiful point. And I think that we sometimes see it as a bit of a tick box at the start of intervention, the goal setting. But I think if we spent a lot more time actually and effort really nutting down exactly, you know, what is meaningful to these people, what their dreams are, what their aspirations are, what they really want to achieve, that it would actually make our interventions much more effective. And hopefully, you know, make a bigger difference to the clients that we see.
Yeah, that's a wonderful one.
Yeah, and I think that leads really nicely into the next good practice recommendation, which was that clinicians should determine the factors that are limiting goal achievement. So could you talk us through what that process would look like, you know, in a clinical setting?
Yeah, so I think this really speaks to the fact that even if two people had the same goal, it might be completely different things that are limiting their ability to do that goal. So it's really, really important for us to actually observe the person being able to do the goal. So if the goal was being able to ride a bike, for example, it's really, really important that we say, all right, let's see what you can do already. Let's see what's holding you back. Because for one person, it might be that they can't get onto the bike. For another person, it might be that they've got no idea how to pedal the bike. For another person, it might be that they can't hold on to the handlebars. So it really speaks to the fact that we need to observe what is happening with that actual task or goal. And I think that that's a little bit different probably to where our headspace was 20 years ago, because I think we probably automatically went to underlying impairments and thought about, you know, if this person wants to ride a bike, are their legs strong enough? Do they have the grip strength in their hands? Is their balance good enough? So I suppose we really know now that there's lots of factors in terms of being able to do a task, and they're not always about those underlying impairments. So sometimes, and bike riding is a beautiful example, sometimes people actually just don't know exactly where they need to put their feet to start off. Once you get them starting that off, actually they're completely strong enough. Their balance is completely fine. So we could be spending so much time and effort on those underlying impairments, but sometimes it's just something about the task or the environment that is the issue that's a quick and easy solution.
So, you know, really understanding the context so that you can then, you know, make your time with your client as, you know, enriching as possible.
Yeah, absolutely. And acknowledging that it's completely different for each individual as well. So not assuming that they're not able to do a goal based on their condition or their diagnosis, which is so, you know, good. We have all this amazing skills and knowledge and we automatically go there because that's what we've always done, and it's amazing that we have all this background skills and knowledge, but sometimes it's just actually really important, or well, always, to observe the person doing their goal, because sometimes it's something completely different to what we would have thought that's stopping them from being able to achieve it.
And those are great things to sort of push the boundaries of our own expectations as well. And, you know, we all have a tendency to go back to what we know. If we're not sure about a particular situation, we go back to, you know, what we're comfortable with. And this really, it's worth acknowledging this is a shift in how we think, because like you said, Michelle, it is so true. We used to just think about what are the impairments that are contributing to us. We address them first before we do the actual activity. But by that stage, the child's like, but I just want to do the activity. And that was their goal. So it brings it back down to that. It sounds simple, but it's so important. And
I think we, you know, through research, we've figured out too that, you know, if we work on balance and leg strength, for example, it doesn't mean that the child will be able to ride their bike. We've figured out that to ride a bike, we need to practice riding a bike. So that's an awesome shift. And it means that, you know, children and families can really target their time and effort where they want it to be targeted.
And I mean, that's perfect into your third recommendation. So good practice recommendation 3 just so happens to be intervention should directly target the child set goal. So the direct quotation from the paper was actively practice goals rather than attempting only to address underlying impairments. And here we talk a whole lot about this whole hands-off approach as well. Can you talk us through that?
Yeah, so I mean, we've sort of touched on it just before, but really this just speaks to the fact that we know the most efficient way to improve on a goal is to actually whole task practice that goal. So we know that breaking it down or working on underlying impairments will not necessarily lead to goal achievement. So I guess this really speaks to the fact that if we're thinking of things within a tiered approach, I suppose, let's go to whole task practice and practicing the whole goal first and thinking about within the context what can be worked on. And then if we need to, break it down. But don't start with breaking it down and working on impairments or assuming that if we change something about the way we move or how strong our muscles are, that will necessarily lead to goal achievement, because we know now actually that is not necessarily the case. That even though we would assume that working on those underlying impairments would have a carryover effect into functional goals, that's actually not necessarily the case.
Yeah. And there again is a bit, I know that there's these challenges in our thinking when it's quite a shift, because previously in our training it was very much hands-on and when we talk about hands-off, we're not always saying our hands are off. It's just it's a mind shift of kind of going, well, I want the child to be as active as possible. What would you say to people who are sort of find that sort of shift in language or thinking a little bit more challenging from their training?
Yeah, I think that it's completely fine to feel uncomfortable when we're changing interventions, and it will be forever changing. In 10 years' time, the evidence will tell us different stuff. It's not that we have been doing the wrong thing. It's that our knowledge about what works best has changed and improved. So I suppose we know, like in the last 20 years, we have learnt a lot more about neuroplasticity and the best way to, I guess, get that neuroplastic change or, changes happening. And we know that we actually need to actively initiate our muscles and movements to actually have that carryover effect into active movements. So whereas previously we thought that those hands-on passive movements were really effective, actually we now know that trying to get that active movement happening is more effective and leads to better long-term change.
I remember when we spoke to Professor Iona Novak in a previous episode of the podcast, she explained it really beautifully, and she said, because sometimes it can be challenging to have this conversation with parents because they might be expecting, they might have certain expectations around therapy and what that looks like, and they might sometimes be expecting more of a hands-on approach. And she said, but whose brain is working? If we're doing, if I'm going through all the motions with your child, whose brain is learning and moving. And I think that's something to remember, particularly in light of this recommendation.
Yeah, I think that's a beautiful way to put it. And I probably word it similarly like that to most families and parents around, often we have that discussion, particularly for infants, around passive handling and stretching and whether that is a really high priority or whether active use of our limbs is a high priority. So we would definitely have that discussion around, we know that active is better in terms of long-term independence.
Yeah. So, Michelle, good practice recommendation 4 is that intervention should be enjoyable and motivating for the child. I think we probably all intuitively understand why, but could you explain to us, why that is a recommendation?
Yeah, and I think that there's probably 2 things here. We know that interventions that are fun and enjoyable, the child will be more motivated to do them.
Yes.
And really we know that if we're practicing the goals that the child has set themselves, they'll probably be motivated to do them.
That's right.
But I think that this recommendation specifically also spoke to the importance of not carrying out interventions that are painful for or distressing for kids.
Yes.
And that's probably particularly when we consider kids that might not have great communication skills, so may not be able to tell us that something is really uncomfortable and they want it to stop, but we can usually tell when something's uncomfortable and they want it to stop. So this really speaks to the fact that we need to weigh up the benefits of intervention. And if something is really distressing or painful and the child is really disliking it, maybe we need to reconsider the intervention that we're doing and consider whether there is an alternative intervention and what we're aiming to achieve with the intervention.
Absolutely, because there can be an actual physiological response to distress in children, can't there?
And absolutely, and certainly, particularly in the neonatal population, we know there's lots of studies around cortisol and stress and the long-term negative effects that can have.
Yeah.
Yeah, I think that's a great one just to highlight and to reinforce that, the reasonings behind that too. And that leads us into the next recommendation, number 5. Practice of goals should occur within the child's home or community environments where it's possible. And why is this important?
Well, we know that just because a child is able to do something in a clinic or in a therapy space, it doesn't mean they'll then be able to do it at home or at school or within their community. So this really speaks to the fact that context it makes a difference to whether we can do something or not.
Yeah.
And, we don't really want to aim for a child to be able to do something within a therapy environment. We want to change their actual life. We want to make them less dependent on coming into therapy and seeing us. So that really speaks to the fact that we want the changes that we see to carry over into real life. And we know that the best way to do that is for practice to happen within real life settings. So if a child wants to play basketball, for example, we know that, we use the basketball that they're going to be using with their peers at school, because if we use a lightweight or smaller basketball within the therapy session, there won't be any carryover to what they can do with their peers at school. Yeah.
Oh,
love
great.
that. The next one, good practice recommendation 6, is that parent-delivered intervention can be used to supplement face-to-face therapy when appropriate education is provided. Could you explain to us, what that appropriate education might be and what that looks like?
Yeah, so I suppose this recommendation really speaks to the fact that we're limited by funding. In most cases, everywhere around the world, we're limited by funding. And we also know that for functional goals, there needs to be a certain amount of practice for us to be able to do it. We know that based on motor learning theories.
Yeah.
And really, we can't do enough face-to-face therapy to improve really quickly. So we need to practice at home, and parents can support that practice if we provide them with the skills and the knowledge to be able to support that practice, and if they think that it's realistic for their family. So I think, the consumers that gave feedback, one of the things that was really important for them to highlight was that for some families, they don't want to do therapy at home. And as clinicians, we need to really respect that and just have the conversation around whether it's realistic. The majority of parents will want to practice and support their kids however they can. And as clinicians, we just need to provide them with the skills that they need to be able to support that practice at home. So providing, those really specific goals and having a discussion around when goal practice might happen, where it might happen, how realistic it is for it to happen on a daily basis, or, when within their family, and what other supports they might be able to bring on board to make that practice happen.
That's so useful. Yeah. And then the next one is that, and I think, we've kind of touched on this in various ways already, but good practice recommendation 7 is that children and young people and their parents should remain the decision makers throughout your time with them. How can we as clinicians support this?
Yeah, so I think, we even touched on this in the very first recommendation around the child and the family setting goals. And I think that we can support this by providing them with the skills and the knowledge. So letting them know what our expert knowledge is, but also, I suppose empowering them to feel like they can make their own decisions and that they don't have to. I suppose it's really about us acknowledging the family's expertise and working together as a team, as opposed to being the expert that is telling children and families what they need to do. And this is a really big change for lots of people, actually. And I think that this is almost a bit of an uncomfortable space sometimes when people come to see you as the professional. Some families just expect that you will tell them what to do. And they expect, you're the expert. You tell us what's important. You tell us what to do. So this is a shift in thinking for lots of families, but also clinicians. It's sometimes uncomfortable for clinicians to say to families, what do you think? What do you think would work best? What do you want to work on? So it really speaks to the importance of having that discussion. And if families want our expert knowledge, then us sharing that knowledge with them. But also, facilitating the fact that they may choose to do things that we wouldn't necessarily choose. And I suppose it's about providing options. And that's one awesome thing about, these guidelines, is that it enables clinicians to know what is currently best practice. So we can let consumers know, these are the options for your child. If you're working on this particular goal, what do you think is realistic for your family? Rather, I think as a professional, professional, it's easy to get into the groove of using certain interventions that you're really comfortable with.
Yes.
I think it's really, really important for us to be a bit more open-minded sometimes and really adapting to individual situations.
Yeah.
That's a great
I love
point.
that because you talk about your clinical skills, but there as well, we're talking about our coaching skills, our motivational interviewing skills, and it's communication,
relational skills.
Part. Yeah,
absolutely.
And so, investing into time to doing that and learning off each other and having those discussions are actually really powerful. And our families deserve that, our ability to be able to convey information in that kind of way that's not threatening, it's open and it's encouraging, and it empowers them to make a decision. So I think that really highlights that too.
Yeah.
Absolutely. And it's really respecting that families, a lot of the recommendations that we would have made, families have probably tried lots of those things already in the past. So it's really respecting the family's expertise, I think, and asking them.
Yeah. And I love your next recommendation, good practice recommendation 8, a high enough dose of practice needs to be undertaken to achieve functional goals. And one of the quotes that you have in the paper is clinicians and families may need to plan how the effective dose will be achieved, and clinicians should inform families when an intervention is unlikely to be successful if their dose does not practice enough to reach the threshold dose. So, what is that threshold dose? What does that actually mean?
I know. I think everybody always wants a perfect number here.
The magic number.
The magic number. And unfortunately, there is no magic number. Depending on how complex a goal is and depending on the individual and the family situation, the dose will absolutely vary. Yeah. But I suppose we know more complex goals require more practice. And we know that certain interventions, the research tells us that certain interventions will require higher doses of practice than other interventions. So I think that's a really important consideration for professionals and also discussion that you need to have with families because, families read these guidelines too and they might come to you as a professional and say, I really want to do constraint-induced movement therapy, for example. And if they do, that's amazing if it's appropriate for them. But you need to have that discussion about how often they will need to practice every day for an intense period of time and whether that's realistic for them or not. Because if it's not, then there is no point at doing that intervention at that point in time. Yeah,
and those end up becoming time and resources spent without the outcome that you're hoping to achieve, and that can cause frustration. And
absolutely.
This also speaks to the number of goals that you need to set as well, because I think, if there's quite a difference between having 10 goals to work on in a period versus 3 or 4, what would you say around that?
Yeah, absolutely. And I think, again, there's no magic number on this, but I think as an expert consensus, we definitely had discussions around this. And I think within recommendation 9, actually, it sort of states that generally we would say working on 3 goals at a time is enough. And that is 3 goals across all areas of life. And sometimes it's challenging for different disciplines to let go. And I suppose that comes back to this idea that families be able to just identify what the highest priority at that point in time is.
Yeah, and those 3 goals are goals that are prioritised by the child and the family and not the clinicians who are working with them.
Yeah, and we don't jump in there with you can just work on this on the side and that on the side. We just respect that those are the things they're working on at that point in time. Yeah.
And I think the other really important part of recommendation 9 is that it's a team approach that should be used to set the goals and determine the intervention regime that you're using. But I think perhaps the really important point here is, sometimes when people think of a team or teamwork, they think of, lots of people and potentially overburdening the family with lots of different opinions and ideas about how things should work. But the idea of teamwork in this example is to actually streamline that process for families, isn't it?
Yeah, absolutely. And make sure everyone is on the same page. So you're all working towards common goals and I think professionals, particularly if they're not working within the same facility, being in communication with each other can really decrease some burden on families to make sure that everyone's on the same page. And I suppose, working towards those prioritised goals is a really, really important point. And I think something that's a bit of a challenge probably within the Australian context since the introduction of NDIS, because often disciplines are working separately and, you know, often they're sort of just doing their weekly or fortnightly sessions as opposed to the whole team doing a bit of a reset and a prioritisation of what the most important goals are at that point in time.
Yeah, that's such a great point to highlight because I've certainly seen that difference in the 17 years I've been a physio for now. Like, you know, I remember the block funded days where we're all in the same team and you're all there, you discuss, coordinate, you could bring people in, whereas now you're much more separated. Even if someone's part of one main service provider, they have the choice of engaging in others. You may not necessarily know who they might be sometimes, and how do we get the communication across? It just requires a lot more creative thinking in terms of how we can support our families better as we're going through this whole, you know, process of really just understanding NDIS and our service models as a result.
Yeah.
So now this leads us into your evidence-based recommendations. So number 10 is mobility training using a goal-directed approach with a focus of practice within a real-life context compared to no intervention is a strong recommendation. Can you just talk us through this first evidence-based recommendation now with regards to mobility training?
Yeah, so I guess this really speaks to a lot of those general practice, good practice recommendations that we've already spoken about, is that we want to consider real life practice and that whole task practice as much as possible. So if we want to, for example, improve someone's walking ability, we can do that by practicing walking and what we call overground walking, which is just walking on our normal natural environments, which the awesome thing about this is that it doesn't require expensive equipment and we can do it anywhere, which is really, really amazing. But I think one other thing that came out of the research was that families find it more feasible to increase the dose of walking practice if they have a treadmill. So they can do something like, you know, if parents are cooking dinner, the child can be walking on the treadmill. So that's something that if there is the option of having a treadmill available, then that can really help increase the dose of practice, which will increase the time frame within which we will see improvements.
Yeah, and again, it's very whole task practice here, isn't it? I mean, that can't be understood. You know, like it's so important.
Yeah, and it really is. You know, if we're sticking to those key, you know, those 9 key principles that we've already talked about, like just going back to that, setting goals, practicing the whole task, you know, that can apply to all of these evidence-based recommendations around mobility, hand function, leisure and self-care.
And can I talk quickly about children classified within GMS level 5? Commonly there's very little effective interventions we know about for this group of children. So I think it can be a little bit challenging sometimes to come up with ways to support. So how would you encourage and to sort of be able to recommend to clinicians on how to use these guidelines for children with that classification?
I think it's really hard because we really are lacking evidence and research to guide what we do with kids who are GMFCS5 or have really severe gross and fine motor skills, so really severe impairment. And I suppose we know that there are ways, and there's some lovely recent research out there, that there are ways that we can tap into things that they're really interested in and that will make a big difference to their life that won't necessarily be, I suppose, a real focus on active practice, but maybe adaptations might make a bigger difference. But I think that that's a real gap in our research. And so this is a lovely space that we would love to see future research in. And I think it's really important to highlight that, is that it would be nice to have more support and guidance around how we can help these kids.
That's a really good point.
Recommendation 11 is another evidence-based one, and that's around hand use in functional activities. And again, we're talking about goal-directed, whole task practice. But there is a decision kind of algorithm around hand use in functional activities. Could you explain to us and the listeners how that works?
So I mean, hand skills or research around using our hands is probably the biggest body of evidence that we have in cerebral palsy, which is awesome. There's lots of great evidence. There's lots of great evidence to tell us that these things work, and that's really nice to know. So the intervention options are really probably primarily there's a few. So constraint, bimanual intervention, which includes habit or habitual, co-op or, cognitive interventions, and general goal-directed interventions. So I suppose when people see that list, particularly people probably who are less experienced or haven't necessarily used those interventions much, it can be a bit overwhelming, and it can be a bit overwhelming to know who to use which intervention with.
Of course.
And that will really depend on the person and the goal and their family and what is realistic. Yeah. So we decided as a group that it would be good to come up with some kind of algorithm to help clinicians make that decision. Yeah. I'm actually not a huge fan of algorithms, but I think that we can't use a cookie cutter approach for anyone. No, unfortunately, we can never have this yes, no, follow this, follow that, because every individual and their family is different. Yeah. So it's really working through that process of, for this goal, for this individual within their family, what will work best to lead to goal achievement.
Yeah, no, that's wonderful.
Yeah, and for clinicians who might be interested in accessing that algorithm, where would they find that?
So that algorithm is included within that publication.
Yep. Fantastic.
It's a great place. I looked through it and it was actually really nice to think it through and actually think about the patients that you work with and where you could make those decisions. But, it does draw on, it gives you the evidence, but you as a clinician still need to think through of what it is that matches for your child, for the child you're working with as well. It's really cool.
Yeah, and have that discussion with the families around. So it kind of is a good context for having a discussion around what the options could be, I think.
Yeah. And another encouragement to go and read the paper in full for all of our listeners.
Yeah, that's right.
The next one, Michelle, evidence-based recommendation 12 is around self-care. And I think, again, this is a strong recommendation and it's something that we touched on in relation to hand use within functional activities as well. But some of the interventions that you touched on, one was co-op. So could you just talk to us a little bit about, who would benefit most from co-op as opposed to habit or habitual, or, how you go about, again, making those decisions?
Yeah, and I suppose those two specific interventions are named in there, but also goal-directed therapy is named. So really, if you're sticking to those 9 best practice principles, you're probably doing goal-directed therapy, which doesn't require any formal training. So co-op and habitual both require formal training. Co-op, there is a 3-day or 2.5-day training that you need to do. And co-op is really focused on teaching the children this problem-solving skill of what we call goal, plan, do, check. So it's really focused on getting the kids to think about what they're doing and come up with a plan for how they might be able to do their goal better and trying it and then reviewing it. So co-op is quite focused on this cognitive aspects of function, I suppose. And because of that cognitive aspect, it really is appropriate probably for people 5 and up. Yes. And we know that it's appropriate now across lots of different diagnostic groups. And I think excitingly in the cerebral palsy population, co-op has been quite effective for kids with quite significant dystonia. And that's exciting because we don't have much research to tell us what is really effective for those kids. And we know that these kids are often, their intelligence is often quite good, so it's a great intervention for them. So habit or habitual, and people who have read about them have probably read about them primarily run within school holiday camps.
Yes.
So they traditionally have been run as 90 hours of intervention. It's a lot of intervention. And there is some preschool habitual camps that are being run in Brisbane at the moment that are smaller than that. I think it's 45 hours of intervention that they're doing, which is still a lot, and it's face-to-face intervention, so it's intense. And you also require training. There's no formal training, but Yannick Blainhoff who is the developer of Habitual, actually, I suppose, trains therapists up to do it. So it's tricky for therapists to be trained in doing it. And requires a really big commitment. But there is actually really beautiful gains being seen in the kids that are doing these camps. So overall gains in motor function as well as goal-specific gains, whereas co-op we're really seeing goal-specific gains. And this take-home skill, I suppose, of the child hopefully being able to apply this problem-solving activity to future goals.
And like you say, if people don't have the opportunity to access those training opportunities for co-op or habitual, then there is still goal-directed therapy is always there.
It's always there,
you know,
I think the other important point for self-care to note is that even though equipment is not a functional intervention, definitely equipment can really decrease the burden on families in terms of day-to-day activities and quickly and easily improve function. So we would absolutely encourage equipment to allow for independence where that's possible.
Yeah, that's wonderful. And I guess that leads really nicely into your final evidence-based recommendation, which is leisure. And so can you just in brief just talk us through what some of the recommendations are for improving leisure?
Yeah, so there's really not a lot of evidence out there, and the evidence that is out there is pretty recent. So there's small trials with these participation interventions, so PrEP, which is out of Canada, and Participate CP, which is out of Australia. And really the focus within these interventions is that you're not just looking at a specific activity, you're really looking more broadly at what is happening within the environmental and the social context, and whether there's particular barriers within those environmental, social contexts that you can address to help facilitate participation, which is actually really beautiful. You know, ultimately we're aiming to improve participation. That's right. I think within any interventions we do, it's amazing if we can have those conversations with children and families around how will this work, what's getting in the way, how can we facilitate this happening in real life.
Yeah, that's right. Well, I think what's beautiful about now we've gone through all of the recommendations, it really just shows that, you know, the first few good practice recommendations in terms of being very family-centered, setting goals, looking at whole task practice, it really does summarize, you know, what is best practice in this current area. And Michelle, I cannot thank you enough for all of your time that you've just put in but even just putting it together, let alone talking to us today.
Yeah, absolutely.
Thank you so very, very much.
Oh, thanks so much for having me. It's amazing. It's amazing to get the work out there, and hopefully clinicians can use it, and hopefully it makes a huge difference to children and their families.
Oh, no doubt it will. Look, for everyone who wants access to any of the material that we've talked about as well, we'll have links on our website, researchworks.net, so we'll point you in the right direction of that as well, and all the resources that the team have made are very much available. So we'll point you in the right direction for that. And remember, if you want this recorded as part of your CPD requirements, there's a form on our website as well you can fill out, so we can help you keep a record of that. But for now, we must say goodbye, even though I think we could talk for a very, very long time.
Absolutely.
But we must say goodbye. So thank you so much for your time, and we'll talk to all of you guys again next week.
Thanks, Michelle.
Thank you. Bye.
Bye.